So we're going to talk about an idea whose time has come. I think we can all agree. Healthcare outside of hospital walls. Telemedicine, I understand from reading Fortune magazine, is on track to become a $4.5 billion industry in short order. And the need here is great. So I'm going to quickly set the stage. Medical expenses are the top cause of personal bankruptcy in the United States. There are more than 6,000 locales across the U.S. where there are too few doctors to meet the medical needs of its residents, a trend we only see growing as hospitals gobble up smaller practices. And wait times in some major cities are greater than 100 days to see a family medicine doctor. I mean, this is not a sustainable situation, right? So the good news is there are some solutions. Some solutions are here. So before we get into the nitty-gritty of what you both do, we'll start with you, Hill. If you can just tell us what Doctor on Demand is doing now, and then we'll project later into the future about where you see this going.
Sure, you set the stage really well. I mean, the problems that you mentioned are exactly why we exist today. We started 4 years ago really to solve the urgent care problem and created a medical practice to treat 18 of the top 20 reasons why people go in to see a doctor on the weekend or at night. These are low acuity conditions, rashes, colds, flus, infections, things like that. Very quickly learned that there was a ton of demand because access is such a problem in our country. And so we expanded into mental health, bringing on psychiatrists and psychologists, and really have built out a national practice to address access and affordability of care. And so, as you mentioned, the access being such a big problem, the national average is about 18 and a half days people have to wait to see a provider. So for most people, that's far too long. Certainly those of us who manage their entire life on their mobile device and are always on the go, always traveling, coming to San Diego to conferences, we meet a real convenience need for that population. For other people who live in different parts of the country where access is just not there, right. We may be the only option for them. So the stage for now is really treating very basic things through our platform, and mental health is a really big growth area for us in the last year. We've put a lot of emphasis behind that. We work both direct to consumer in the cash pay market as well as through enterprise payer partners and health plans and self-insured employers. And so mental health has become a big focal area for large employers, recognizing that stress, anxiety, and depression are some of the leading causes of problems in their workforce, and so that's given us a nice tailwind in the last year.
And that's only likely to grow more as sort of wellness and mental health and a sort of 360 approach to what it means to be a healthy person sort of evolves. So yeah, that's great. Jonathan, your turn. Tell us about Healthyio.
So Healthyio is the first company in the world to win clinical approval for a smartphone camera as a clinical grade scanner. We set out 3.5 years ago with the understanding or the notion that as you've just set the stage, and if to borrow from human evolution, we had to domesticate animals in order to grow and evolve. We're going to have to domesticate healthcare in order to grow and evolve. And some of the way to do that revolves around some solutions we've seen here that are 10, 20 years out. We've seen Proteus starting to make an incredible effort and starting to change that. But what we saw as a major force in order to domesticate healthcare was what we call Kardashianomics, or the economics of pop culture around Kim Kardashian, around the incredible evolution, exponential evolution of smartphone camera quality.
Right.
And we saw that as an immediate step through which, with AI that we deployed on the cloud, we can create smartphone images that have become normalized, and by that allowing for people to scan, that's the first product, urine testing at home. We've rolled that out with the NHS in England, with a chronic condition of multiple sclerosis, people who do a lot of urine tests and have to suffer those lengthy doctor's appointments that then are followed up by a lab visit. We allow for them to have the box at home and to scan with their smartphone. So no add-on, no clip-on, no hardware, just taking those smartphone images, the selfie camera, if you will, and taking that into the medical domain.
That's incredible. Practically speaking, for the average person who maybe doesn't have a severe disease for which this is currently being used by the British government, for instance, how does it change? I'm pregnant, I have to have urine tests constantly. So how could this potentially change life for me.
So actually, pregnancy is our second use case. We're about to launch in a couple of weeks. We're going to announce a major partnership that's going to cover 50,000 pregnant women who are at risk, who are, because of their risk level, they have to do urine tests once a week for an entire trimester. So instead of waking up every morning, getting to the lab, which by the way doesn't make sense also from a public health care standpoint, right? You're a pregnant woman, you don't want to be there next to everyone who's suffering from the seasonal flu. So once you've been, a woman who's been diagnosed with at-risk pregnancy takes sort of a care package from the pharmacy. We've integrated that into the HMO that we work with in Israel. And then all those tests are conducted at home and they deliver the results directly to the EMR. That's a model that we want to replicate worldwide. Definitely pregnant women are major consumers where we think we can alleviate the way in which they consume this simple test, but basically, we've built a system which is centralized. In order to consume the simple test, you have to wake up in the morning, stand in line, do what we've received in consumer testing, something women call the walk of shame,
yes.
Walking around with a cup full of hot urine. So we want to get rid of that process and deliver higher quality care.
Great. Hill, and you have some news too with Doctor on Demand and some new offerings that...
We did. We made a major announcement for us today that we have formed partnerships with LabCorp and Quest, two of the nation's leading diagnostic labs, to really enable Doctor on Demand to be an everyday healthcare provider for Americans. So one of the things that we've been hearing from certainly our doctors from the very beginning is, I need more tools to do my job, to practice medicine better. That one was easy. The trickier one was, how do we enable this in a virtual environment, and how do we do it in a way that puts the patient first and in control of the entire experience, because that's synonymous with our brand. And so we've designed a service that will launch this summer, and will enable providers to order any number of the hundreds of labs available today for that patient, and then after the visit, the patient will be able to see a screen on their device that will locate them with a map and show them all the different laboratory locations in their vicinity, along with things like operating hours, what it would cost you, what it costs you with this insurance plan versus the others. So we have insurance information on our patients. So we're really providing a lot of transparency and putting the patient in control of where they go to get their lab. Once they do that, we shoot a notification to them when the results are ready, and if a follow-up visit is required or requested by the doctor, that's easily scheduled with the same provider that had the initial visit. So it's very different than the current experience of going in, having an office visit every time, being told by your provider, you need to go here, and you need to go at this time, to really putting that back on the patient and letting them decide where they go and how they go and when they go.
Right, which, and as we were just discussing, it expands the breadth of conditions for which one could use a service like yours.
Exactly.
The ones where you just are constantly going in. Thyroid disease, diabetes, these sort of chronic conditions that require a lot of follow-up visits.
That's right.
And a lot of labs, yeah. Let's talk about patients for a second. So one thing that's been studied to a certain extent is this idea of the care effect, that simply interacting with a doctor can have a measurable benefit on patients. I imagine there are probably some doctors, when it comes to telemedicine, who are very natural on FaceTime, and some who are perhaps a little bit less natural on FaceTime. Right. So is there something lost there, perhaps?
I think there's something gained there, and I think it's a really interesting phenomenon that we've learned. Our chief medical officer, when he got into this, had some doubts that, can you actually build and establish a doctor-patient relationship remotely? And with video, we're a video-only platform, so we don't do phone calls for that reason, because we feel like it is the best medium for a remote doctor-patient relationship to be built upon. And 100% of the doctor-patient interaction is eye-to-eye contact. And compare that with a typical office visit where you come in and you're shepherded through a waiting room, hopefully not too long, through a doctor's assistant, take vitals, and then doc comes in really quickly, and half the time they're interacting with you, they may be hunched over a computer, typing notes into Epic or whatever it may be. And so what may be a 15-minute interaction end-to-end feels much smaller because you don't have as much FaceTime, so to speak. And our experience is 100% FaceTime. And so we're actually working with Harvard University on a study to look at our data to actually establish and prove the type of effectiveness of a doctor-patient relationship being built on video. So looking forward to seeing how that plays
Interesting.
out.
Can you tell us a little more about that? Or
No, I can't. No. I probably shouldn't have even told you that.
Fair enough. Let's talk about some of the regulatory barriers that we began to talk about backstage. But Jonathan, can you talk about that a little bit because you are it is a medical device, right? So
I think it's important, and that's something we put on our map and our sort of vision early on, that we don't want to have a vision of working below the radar of the regulator. We don't want to shy away from that. We actually do believe in our discussion with the German auditors that audit our clinical performance in Europe, and so far the discussion with the FDA has proven us right in that regard, and we'd encourage any digital healthcare company within necessarily the smartphone domain and AI to engage with the regulators, because we find a very good constructive dialogue there. And to an extent, we also believe that there is a good sense for being conservative in that regard, because we are dealing with people's lives, and when you want to claim substantial equivalence, that you can do our urine tests at home, as you will do it at Quest or at LabCorp, you want everyone to be able to trust that, and that requires 500 patient clinical trial of different age groups, and it requires proving usability. And on the other end, it forced us to build a team that is very robust, and the way that we work, although very challenging, not the classic agile model of working as a startup or trying to make that work together with the regulatory framework. But I think it helped us build a healthy company, which is now scalable into products 2 and 3. And so the regulation and adhering to regulation actually has a lot of positive sides.
I want to get to products 2 and 3, but first let's talk about some of the regulation around telemedicine, because I know that those can be kind of wonky state by state.
Yeah, it's been a very dynamic environment for us in the last several years. I mean, it starts with the state medical boards, right, and being able to give us permission to establish a doctor-patient relationship. That started off slowly and picked up a lot of steam in the last several years once boards realized that, hey, this is actually a net incremental benefit to the population health in my state. What we have seen here lately is we're live in 49 states today, the 50th being Arkansas, which actually just cleared Congress a few weeks ago, and we'll be live there in August. But it's been a long road to get there, and I think what we're seeing now is that we've been video only from the very beginning, because we've been very, very committed to that medium as being the most responsible way to practice telemedicine. And now regulators are starting to agree with us. So in Arkansas, video is a requirement. In Texas, video is a requirement. So there won't be any more phone calls permitted for telemedicine in those states. And I think that could be a trend that continues.
Interesting. And am I correct that in order to practice across state lines, you need to be licensed in both?
You need to be licensed in the state where the patient is physically located. And so one of the advantages to our platform being built in the last 4 years is that it's all on mobile, and so it's able to geolocate you wherever you are. So even if I'm registered on our platform as being from California, but I happen to be in Arizona, we can comply with that law and connect you to a physician who's licensed in Arizona. But there's a lot of machinations in the background in our operation that make that more complex, because we have to have providers who are licensed in many different states to deliver a sub 3-minute waiting time 24/7 by 365. So one of our big promises is the doctor waits on you in our service, and to do that, you have to have a lot of doctors ready, to take that visit.
And how many doctors do you have?
We don't report that, but it's in the I'd say between 0 and 2,000.
Okay, fair enough. Let's talk about the next phases for you, Jonathan.
So I think what surprised us in sort of planning for the roadmap ahead was the scalability of the AI that we built. Because ultimately, when you want to scan a dipstick urinalysis, and that is accidental innovation, the dipstick covers all the visible spectrum, so from the darkest purple through the lightest yellows. And that basically allowed for our algorithm and the data that we built so far, over 1 million data points. I think we are probably one of the biggest big data from smartphone clinical data sets around the world. It allowed for the algorithm to be very scalable, because it can now discern variances of colors with different lighting conditions, different users at a clinical grade. Wow. And through that, sort of scoping back in terms of how solid we feel about the ability to discern color and size, we looked for this next product. And what we're venturing into is based on JAMA Dermatology, Journal of American Medical Association Dermatology consensus paper from November, where a group of dermatologists worldwide sort of focused, zoomed in and said, look, there are too many people with too many phones. We're getting text messages, we're getting WhatsApp messages daily with pictures of an ulcer, a rash, or whatever, and we're asked to diagnose, or we don't know if the red we're seeing is because, you know, the iPhone 6 generates that kind of red under that kind of lighting condition. And so they actually outlined 7 parameters of calibration and what they think should be in a standard medical image, and that corresponds very well to what we have built as a technology, as a backbone. And so we're venturing into that field right now. We're scoping into a field of pressure wounds and ulcers that require nurses to change bandages, and actually nurses today measure with a measuring tape the change over time of a certain wound, the change in color, and they report subjectively. So what we're venturing into is actually standardizing that domain. We don't believe in standardizing it to the degree that we're going to diagnose, at least not in the first, I would say, 3 to 5 years until there's robust data, et cetera, but at least save the nurse's time. So of a, let's say, 18 to 20-minute visit with a patient, 5 minutes of which is, you know, scoping around the ulcer itself, if we can minimize that into, let's say, 10 seconds, we've just saved that nurse 5 minutes in which she can, you know, be in contact with the person, and ultimately standardize all the data that she would otherwise type in or measure subjectively. So that's the next frontier, and that's where our A round proceeds, we're closing our A round in the next few weeks, where our A round financing is going to be focused on allowing for that R&D to take the next phase and then do the right clinical collaboration to get that into market.
Interesting. We're going to go to the floor in just a minute. I do have a follow-up question while you guys ponder what it is you'd like to ask these guys. How do you integrate that into a traditional medical system? I mean, do you, I guess I'm starting with you, Jonathan, like, how do doctors even know that this is available to them, that they could free up 10 minutes of their nurse's time by using you instead of using?
Right, so one of the reasons that we're focused on the NHS as client number one, and now scaling into Israel and then Europe, is that those are less fragmented systems. So the system can, you know, sort of identify, you know, this is a troubled area, this is where we want to focus, and then a part of our team is an integration team, and so we can then integrate pretty much every EMR that we need to operate with, and that's why we're choosing things that are high on the priority. So we don't have to sort of go out there and knock on doors and say, hey, we have a solution for this, but rather looking at areas where the system says that's a big problem area, and whoever has solutions here, please present them. Sure. And that's how, you know, within 3.5 years, we were able to introduce a product into the NHS, which is not an easy system to, you know, interact with.
Great. I think we had someone on the left. Yes.
Ann Barker, Arizona State University. I have 2 questions, actually. One is just hearing this. It's very exciting, by the way. But I'm wondering, so what happens to the classic bricks and mortar hospital, where a lot of this testing, you know, when patients are admitted, is now going on in hospital? Do you see this impacting the way hospitals function, or are we going to have fewer? That's one question. The second is, how do we, those of us that work in educating in medicine, how is this going to change the educational kind of program for the upcoming physicians?
My answer will be quick. I think we're not in any way competing with brick and mortar for lab testing. I think in our world, we're really just trying to provide incremental access to people who otherwise aren't getting these tests, or aren't, maybe not because of access, because of just convenience, in some cases because of pure access. So I wouldn't say that it would have any direct impact on volume that we're seeing today. It would be more incremental.
I think to echo Dr. Agus's conversation with the CEO of New York Presbyterian, and that example of the ambulance that was doing the x-ray and delivering it to the ER before the person goes into the hospital, that's sort of our philosophy. We want to enable those things to happen at home, so when a patient gets to the hospital or to the point of care, there's a greater data set already there, and then the physician consultation can be more effective. We're working with the National Kidney Foundation here in the U.S. to deliver urine testing at home for at-risk patients to discover chronic kidney disease ahead of time, and that has been known and proven in peer-reviewed studies to improve prevention. So whatever you can do at home, domesticate, so to speak, would actually allow for physicians in the point of care or the hospital to be, we believe, more effective. It's not an either or, it's sort of a frontline approach that we couldn't have conceived of at clinical grade until smartphones were what they are, and now we can provide that, and I think that's the adaptation that we're shooting for.
We had one more quick question on the right.
Yes, hi, Dan Zimmerman again from Reinsurance Group of America. Very interested about the medical legal aspects of this, and if research has gone on or conversations with our legal partners as far as given the litigious nature of medicine and the risk of that. And we know that the physician-patient relationship is so important in preventing litigation. And just how might this move forward and impact that whole risk of practice or risk or danger to patients?
Hill, why don't you take this?
I'll start. We work with a insurer who we really helped develop a lot of their models, actuarial models around how to insure a telemedicine practice, right? This isn't something that has been known for a long period of time. If there were wood here, I would grab it when I tell you that we've not had a claim yet, and I think in large part because we're doing relatively simple things with patients. As we expand and we grow, that risk profile probably changes, and so we need to be aware of that and take additional measures to make sure that we're managing it correctly. But our doctors have, on average, 15 years clinical practicing experience when they come into our company, so it's not like they're newbies.
They're used to playing.
They have experience doing what they're doing.
All right. Well, thank you guys both so much.
Thank you.
Yes, wish
Thank
we
you
had
very
more
much.
time.
Thank you.